Good, good
Okay.
evening, everyone. Thank you for joining us on this holiday Monday evening. I appreciate that. My name is Adelita Cantu. I'm chair of Texas PSR, and we're at 6:59. So let me give it another minute, and we'll get started then. So you can get back to your festivities for the evening. And if you could, I would appreciate if you could put your name and your email and where you're from in the chat. That would be wonderful, just for our records. Again, we'll get started in another minute or two. Just want to be sure to give people a chance to come in. Thank you very much. All right, and it is 7 p.m. Again, good evening. My name is Adelita Cantu. I'm the chair of Texas Physicians for Social Responsibility, and I am coming to you from San Antonio, Texas. So I will say, go Spurs, go! We are excited to have them in the basketball NBA uh, Western Conference Finals. So, thank you for joining us again this evening, taking part out of your Memorial Day weekend. I would like to go ahead and introduce our speaker for this evening, Lucy Lee. Lucy is a PharmD, who is a recent graduate of St. John's University College of Pharmacy and is a current PhD student in environmental health sciences at UT Houston School of Public Health. Her research interests focused on environmental impacts of pharmaceuticals, particularly pharmaceutical waste, as well as the reciprocal relationship between environmental exposures and pharmacodynamics. I can't speak for Monday, and
You did a good job.
through her doctoral training, she is pursuing interdisciplinary research at the intersection of pharmacy, environmental health, with the goal of advancing clinically relevant and prevention-focused solutions. So thank you so much for speaking with us this evening, Lucy. I'll turn it over to you.
All right. Thank you, Adelita, for introducing me. Hello, everyone, and thank you for being here today. My name is Lucy Lee, and I am a PharmD graduate currently pursuing a PhD in environmental health science at UT Health School of Public Health. I was introduced to Becky, I think last year, through one of my faculty advisors, Dr. Ferguson. I don't know if he's on here yet, but he is a professor at UT Health Houston and also a occupational med physician. And I'm very grateful for the opportunity to speak today through his introduction. As someone with a pharmacy background who is now pursuing a degree in environmental health, I'm always excited for opportunities like this where I can bring those two fields together. And today I'll be discussing a topic that is increasingly important but often overlooked, especially in areas like Texas where heat is such an issue, on how commonly used medications can increase body's vulnerability to heat-related illnesses, and how extreme heat can also affect medication safety and efficacy. And as heat waves become more frequent and severe, on top of global warming also being an ongoing and unresolved issue, understanding this intersection between, I guess, pharmacy, medicine, and environmental health is becoming increasingly important for both healthcare professionals and public health. And with that said, welcome again, everyone, and I'll be moving forward with the presentation. So by the end of today's discussion, the goal is to inform and clarify on how to first identify medication classes that are outstandingly associated with increased heat-related morbidity. And then we will try to explain go over the physiology and pharmacology, specifically the mechanism of actions underlying medication-associated heat vulnerability. And last but not least, three, to discuss evidence-based counseling points and prevention strategies just to help us healthcare professionals take into action what we learned today in actual medical practice. So, as introduced earlier, extreme heat is no longer simply an environmental concern itself. It is becoming an important healthcare issue as well. Um, just to give some of the statistics, to give credentials, in the United States, recorded heat-related deaths increased from about 1,000 deaths in 1999 to 2,325 deaths in 2023. And this represents a 117% increase, with the steepest rise occurring after 2016. So in the past decade, we've seen a lot more deaths related to health heat stress. And at the same time, heat-related healthcare utilization is also increasing. In 2023, CDC reported about 120,000 emergency department visits for heat-related illness itself, with 92% occurring during the warm season months from maybe May to September. And notably, the highest ED visit rates were observed among working age adults, especially those aged between 18 and 64, highlighting that heat-related morbidity extends beyond older adults alone, beyond the elderly population alone. This trend becomes even more clinically relevant when we consider that our patient population is aging and increasingly exposed to polypharmacy due to multiple comorbidities being presented as the patient population is aging. Many commonly prescribed medications influence the same physiologic systems that are required for heat adaptation, including thermoregulation, fluid and electrolyte homeostasis, renal perfusion, and cardiovascular compensation in general. And importantly, patients often do not present with heat illness as their sole chief complaint. That is just rarely the case. Heat exposure may manifest indirectly through worsening chronic disease control, dehydration, acute kidney disease, acute kidney injury, orthostatic symptoms, and medication toxicity, and etc., and obviously apparent treatment failure. So we need to ask ourselves, how often do we consider environmental heat or heat stress as an equally important contributor when patients present with these symptoms and we're working these patients up? Today's discussion focuses on this very question, where environmental heat exposure begins to interact with pharmacology in clinically meaningful ways. Rather than viewing heat as an isolated environmental exposure factor, clinicians may increasingly need to recognize it as a modifier of medication safety and extreme heat resilience within the body system. So before we go on to discuss medications, I just want to briefly establish the normal physiology, the physiologic response to thermal stress, which in fancy terms is heat homeostasis. Heat homeostasis depends on coordinated thermal regulation signaling process originating in the hypothalamus and it involves multiple organ systems. The primary mechanism of heat dissipation is evaporative cooling through just sweating itself. And the body supports this system by cutaneous vasodilation to facilitate heat transfer. And this process is illustrated on the left side of the diagram that we have here. And at the same time, cardiovascular adaptation must maintain the cardiac output and tissue perfusion, despite the redistribution of blood flow to the skin. So the kidney plays a parallel role here by preserving this intravascular volume, and it maintains electrolyte balance. hence it maintains the electrolyte balance with the kidney function. And this process is illustrated on the right side of the diagram. So most healthy individuals, just in general, normally can tolerate heat exposure because these compensatory mechanisms operate simultaneously and they work in coordination hand in hand with each other. This status is referred to as physiologic reserve being maintained. But heat-related illness begins to develop when physiologic reserve becomes insufficient to maintain this homeostasis. And once these mechanisms begin to fail, heat exposure no longer behaves as an isolated environmental stressor and it begins to alter medication handling and therapeutic response to drugs. So medication classes can interfere with different components of this heat adaptation process within our body. And to just briefly go over the list of mechanisms of impairment, some impair the thermoregulation process directly by reducing sweating and just eliminating or limiting the evaporative heat loss in general. Or others can increase the intravascular volume depletion, or some can alter renal hemodynamics, reducing the body's ability to preserve the perfusion rate during prolonged heat exposure, just being exposed to heat in general. Or others can blunt the cardiovascular adaptation and reduce the increase in cardiac output or the process of blood being distributed to the organ system. And this can normally be supported by heat dissipation otherwise. And subsequently, progressive dehydration may also alter the pharmacokinetics of drugs already in the system. And this happens specifically by as renal perfusion declines, clearance of renally eliminated medications may decrease, and this results in an elevated serum drug concentration and therefore increased drug toxicity risk. And as mentioned, these effects rarely occur in isolation. They all work hand in hand, and therefore, in many patients, particularly those with polypharmacy, with multiple comorbidities being presented at the same time, chronic disease patients, such this multiple mechanism overlap, just in general, overlap with each other and cumulatively reduce heat tolerance within the body system. So cardiovascular therapies are some of the most clinically relevant medication classes to discuss within our topic today because they interact directly with physiologic heat adaptation. As we all know, diuretics, by their mechanism of action, they increase urinary losses. But in extreme heat, they may accelerate dehydration and electrolyte abnormalities. ACE and ARBs may also alter renal autoregulation under conditions of reduced circulating blood volume or fluid volume. And also beta blockers introduced another challenge by their mechanism of action to increase heart rate and cardiac output that normally support the heat dissipation process. And importantly, the concern is not that these therapies are inherently unsafe during summer months. Rather, the clinicians should recognize that during thermal stress, these medications may decrease body's resistance against heat stress and making presentations of hypotension, symptoms like hypotension, acute kidney injury, symptomatic heat intolerance like excessive sweating, shortness of breath, these are more prominent in these cases. And this process as a whole becomes particularly important in older adults and patients receiving multiple cardiovascular agents, which is quite commonly the case considering cardiovascular diseases have so many comorbidities. being presented altogether. And we move on to anticholinergics. I think anticholinergic medications in and of itself, they in their inherent mechanism of action, the primary concern with them is its role in potentially impairing the normal heat dissipation process. Just sweating is one of the body's most effective thermoregulatory mechanisms, and anticholinergics, again, with their inherent mechanism of action, they directly suppress eccrine sweat gland function. And as a result, patients may continue generating heat normally, but become less efficient in dissipating it through evaporation. So, for example, consider an older adult taking diphenhydramine nightly for sleep and oxybutynin for for overactive bladder during a period of prolonged summer heat. And this patient may not initially present with classic heat illness symptoms, but the presentation may appear as fatigue, dizziness, confusion, reduced exercise tolerance, falls even, or progressive dehydration. And another example is an older patient receiving amitriptyline, for example, and they report increasing intolerance to outdoor activity despite stable cardiovascular status prior to those symptoms being presented. So these presentations can be easy to attribute to maybe aging or cardiovascular disease comorbidity when impaired thermal regulation may be contributing but being overlooked when discussing plan of care. Psychiatric medications also introduce even more complex interaction between the pharmacology and environmental exposure and also behavior science. But first, some medications directly impair thermoregulation. For example, antipsychotics, particularly agents with dopamine antagonism and anticholinergic properties, they together may impair hypothalamic temperature regulation and reduce the adaptive heat responses. Patients may, again, generate heat normally, but lose efficiency in dissipating it. And secondly, behavior responses become very important, and SSRIs or SNRIs, they may contribute indirectly through altered sweating patterns and fluid regulation. Thirdly, sedating psychiatric medications, they can reduce environmental awareness, just being aware of heat or self-recognizing that they are hot or they are sweating or they need water. And so therefore, these self-recognizing early symptoms of heat danger is impaired in these scenarios. And I want to slow down here a little bit and discuss more in detail about lithium. Lithium is the guideline-directed first-line therapy for bipolar disorder. And unlike some of the previous examples discussed, the primary concern with lithium is not the impaired thermoregulation, but the altered drug clearance process under dehydration conditions. So to go over what happens when lithium is not cleared completely, lithium is cleared almost exclusively by renal. And because of that, renal lithium reabsorption closely follows sodium and water homeostasis, so excretion and reabsorption. But during heat exposure, sweating, reduced oral intake, and intravascular volume depletion, all of this may increase the proximal sodium reabsorption. And this can secondarily increase lithium reabsorption and eventually reduce lithium clearance, and it accumulates within the body system. And as a result, even relatively modest dehydration may produce disproportionate increases in serum lithium levels and precipitate toxicity. Clinically, this becomes important because patients with lithium toxicity may not initially present with classic heat illness symptoms. But for example, a patient receiving lithium who develops several days of poor oral intake and prolonged summer heat exposure may instead they can present with tremors, nausea, just like confusion, ataxia, or even altered mental status, while underlying contributor is heat-associated lithium accumulation rather than isolated environmental heat exposure. And finally, another consideration is hyperthermia syndromes. Antipsychotics may overlap clinically with neuroleptic malignant syndrome, while serotonergic agents like SSRIs, they may complicate assessment through serotonin toxicity and excessive levels of serotonin within the body system and autonomic dysregulation. Recognition of medication contributions like these, with the symptoms they present, may improve both diagnostic accuracy and management. So it's important for clinicians to also take into consideration that maybe for patients who are taking psychiatric medications, maybe heat stress could be a factor to whichever symptoms that they might be presenting, at least over the period of time where heat is excessive, like from May to September, maybe. I feel like it's longer here in Texas, but um, yeah, moving on to the next, I think this is the last drug class. Patients with diabetes, they represent a particularly vulnerable population because extreme heat exposure affects both their physiology and their plan of care. So first, heat alters fluid balance, and during prolonged heat exposure, sweating and inadequate fluid replacement will progressively lead to dehydration and reduced effective circulating volume. This becomes especially important with medications that already influence fluid status, like the SGLT2 inhibitors, which promote urinary glucose and water excretion through osmotic diuresis. And under heat stress, following dehydration, this may amplify volume depletion and contribute to dizziness, orthostatic symptoms, worsening renal function, hyperglycemia, and in some cases, increased risk of diabetic ketoacidosis. And that is a severe chronic condition. Secondly, heat exposure may destabilize glycemic control. As dehydration progresses, counter-regulatory hormones will most likely increase and glucose concentrations may rise. But at the same time, reduced oral intake during periods of extreme heat, just because of loss of appetite or things like that, combined with increased physical activity, may predispose patients to hypoglycemia. So there's both risks of hyperglycemia and hypoglycemia. And in cases like this, especially in patients receiving sulfonylureas such as glipizide or glimepiride, both very common diabetes medications, their bodies will continue stimulating endogenous insulin release, even when caloric intake is decreased and it's not enough to suffice the body's working conditions. So, for example, a patient skipping meals maybe during prolonged outdoor work or excessive working hours that are exposed in extreme heat may present with fatigue, weakness, confusion, or like recurrent symptoms of hypoglycemia, despite no recent change in medication dosing or medication frequency or whatsoever. And thirdly, heat may directly affect medication efficacy. So we'll discuss more about this in the following slide, but especially in insulin, we all know that insulin must be refrigerated before being administered, and that is for a reason, right? It's for maintaining structural stability. So the storage conditions are there for a specific reason, and that is usually associated with the potency of the medication. And exposure to excessive heat may reduce its potency, like insulin potency, and clinically, patients who received these kinds of medications that are so to speak, defected, they may present with unexpected hyperglycemia, worsening glycemic control, and other apparent loss of therapeutic response to insulin. And again, these symptom presentations may initially appear to reflect just mere disease progression or just lack of therapeutic response, just treatment failure. But in reality, heat exposure and medication performance could be the actual contributors of these cases. For patients with diabetes, anticipatory counseling and medication review, therefore, are very needed and become especially important during periods of prolonged heat exposure. So until now, we've focused primarily on how medications can alter patients' bodies' adaptation ability to excessive heat. However, extreme heat may also directly affect the medications themselves, like it does to insulin, discussed just now. And majority of these medications are IV or IM medications, injections, rather than PO, as they just depend heavily on maintaining the temperature stability to preserve medication potency, structural integrity, and delivery performance even. And insulin is perhaps the most widely recognized example. But in other cases, similarly, like inhalers and even EpiPens, they may exhibit altered delivery characteristics after prolonged temperature exposure. And also biologics are also on the list because they contain proteins and they're particularly sensitive to protein stability or instability. And when heat adaptation fails entirely, medication-related effects may converge into severe heat illness requiring escalation of care, which we will discuss in the following slide. So at the end of the spectrum, all of this is heat stroke. And this condition should be viewed as a systematic failure of thermal homeostasis within our body system. So heat stroke is characterized by elevated core temperature accompanied by neurologic dysfunction. So it impairs the brain. Patients with heat stroke may then develop critical care conditions like shock physiology, intravascular blood depletion, rhabdomyolysis, even acute kidney injury, which could progress into chronic kidney injury, chronic kidney disease, hepatic dysfunction, coagulopathy, and ultimately multi-organ failure. And medication effects may amplify these processes through impaired compensation, altered pharmacokinetics, like we discussed earlier, or direct toxicities that are accumulated within our body system. In my opinion, medication review should become part of heat illness assessment, and especially in patients presenting with the following examples symptoms like recurrent heat intolerance that are unexplained and recurrent AKI that is unexplained, altered mental status, especially in warm weather seasons, hypotension or any persistent symptoms like these that are unexplained whatsoever, despite supportive care. And after recognizing medication-associated contributors, escalation of care should be decided accordingly. So unfortunately, drug-related heat morbidity is more susceptible in certain vulnerable populations, and older adults are on this list. They frequently have reduced thermoregulatory reserve and greater medication burden. patients with cardiovascular, endocrine, renal, and psychiatric diseases that are receiving medications that we discussed earlier. They may have less physiologic flexibility during thermal stress. And also, it's important to note that socioeconomic factors like occupational exposure and housing instability, they can also further reduce adaptive capacity. As shared across all previous slides, actually, heat vulnerability should not be viewed solely as an environmental issue. Rather, it reflects a complex interaction between environmental exposure, of course, underlying disease conditions, medication clearance complications, and access to protective resources like housing. And well, it can sound very complex and it can sound like there's no one cure or one solution to all of these problems. But the upside of this complexity is, however, is that there is more room for individualized anticipatory care based on the specific need of each of these vulnerability conditions. So now I would like to switch gears, and I know we've come a long way. The question is, how should all this information translate into medical practice? So, clinicians are, I believe, uniquely positioned to reduce medication-associated heat morbidity before it progresses into severe conditions like heat stroke, as we discussed earlier. And this does not necessarily require major treatment changes. The proposition from me today is to involve incorporating heat exposure just into routine medication assessments and maybe consider identifying patients with reduced physiologic reserve, inviting pharmacists in plan of care in reviewing medications that may impair adaptation, discussing hydration, the importance of hydration and storage conditions, and setting these expectations for symptom for recognition of symptoms that may not be so apparent. And for selected patients, this may also include closer follow-ups, maybe during periods of prolonged heat exposures and maybe in the summers. Have them do doctor visits. If they do it, every 3 months, do it every month during the summer months. And I just want to stress that the broader goal, it's to move from reactive management to proactive, anticipatory medication-informed prevention. Um, Although these interventions occur, at the bedside, the implications extend beyond individual patient encounters. I think from an environmental health perspective, as temperature rises, healthcare systems will likely encounter increasing rates of medication-mediated vulnerability. And this expands the conversation beyond emergency response, emergency department visits, and more toward prevention, preparedness, and interdisciplinary work among physicians, pharmacists, and public health professionals. And that concludes my presentation. And at this point, I'd really just like to open the discussion and invite any questions, comments, or reflections. I know that this presentation, rather than ending with like a single conclusion or like a single solution, I just wanted to leave us with several discussion prompts because I think these topics raise questions that extend beyond individual like medication classes that we went over today. I certainly don't think the answer is to broadly modify or discontinue the current therapies or current guideline practices. But perhaps the discussion is whether there are opportunities, right? Opportunities to become more proactive just by being informed. being informed of how specific mechanism of actions of these medications can actually what they do to our bodies and how they influence our body's thermoregulation process and doing the appropriate counselings to patients for pharmacists, but doing active medication review, occupational guidance, giving occupational guidance, or simply just by asking one additional questions to patients when they're doing doctor visits, like how has the recent heat been affecting you? Um, and with that, yeah, thank you for being here today. And I'd love to hear your thoughts and open the floor for discussion. Thank you.
Thank you so much, Dr. Lee, for a very informative and thought-provoking work there, something that we really don't think about. And if I could take a point of personal privilege, I can give you the first question. Two things, maybe two, is when you talked about diabetes and diabetes medications. Is we have the problem all over Texas, but in San Antonio, we have twice the national average of
Mhm.
diabetes. And I people don't get that information about the precautions they need to be taking
Mhm.
during their provider visits. And I think it's an issue of just not having the time to do it, right? Providers may not have the time to do it. So it certainly calls on us all in the community to raise awareness of it. And the second thing is, I'm thinking about our vulnerable populations that have to work outdoors, that maybe have to take the bus, right?
Mhm.
Um, and although they do have their medication because they may have health insurance to get their meds, they don't necessarily have the public transportation where they can sit in a car going from home to work.
Right.
Um, so it seems like this is even more of an issue in terms of increasing vulnerability.
Mhm.
I was wondering if you could speak to that.
First of all, thank you. Thank you for your comment. I definitely do agree with you on that. This is an issue that extends beyond just clinical practice. I think I did briefly mention this in one of my slides, but a lot of socioeconomic factors also play a role in this. Like, I know you mentioned transportation, but also housing instability. What if someone just doesn't have a stable roof on top of to have just like a good night's sleep in a reasonable room temperature environment, right? Um, so I I definitely do think, but however, there is room for always our primary providers to just inform these patients, right? Whenever whenever they do a doctor's visit that their insurance does cover, um, just have this talk and inform these patients that they are at risk. And sometimes, just by informing patients can do a lot to have them take into their own hands and prevent do and take whatever prevention strategies that they deem available around them. And I think, also community pharmacists, they can also play a big role in this when they just come into the pharmacy. The diabetes patients, they come into the pharmacy to just take their um, regular diabetes medications, just inform them that, this can potentially, by taking these medications, but also being in excessive heat environment, you are at risk. And I think as clinicians, because we just know so well how to clinically, how to clinically treat them so well. We often take less into consideration how non-pharmacologic or just counseling in general, counseling points in general, how they can do magic in patients like this who are more vulnerable.
Yes, and I'm wondering too if there is some a room or a space where our municipalities could do some help with this raising awareness because I do have put out heat advisories. I wonder if those heat advisories can include some of this information as well.
Yeah, I think that's a great idea. I'm pretty sure there might be some government. I don't know if there
Yeah.
might be governmental regulations that are involved in the process of getting these words out, but I think that's a great idea. Yeah.
Yeah. I do want to point to the chat box. Micah has a point, 2.5, absolutely, but we need more training. I'm already thinking about my patients. I recently discharged from the hospital and how many of them were impacted by the recent heat, humidity, and how many we may see soon with summer travels or activities. Excuse me, that was from Micah. And then Brett, hi Brett, great presentation. Are the pharmaceutical companies beginning to place more emphasis on listing heat stress as an adverse effect on a given medication warning label?
Hmm.
If not, is there any action on the part of prescribers to increase this emphasis on the warning label?
Dr. Ferguson, that's a great question. I unfortunately I don't have an answer to that. I'm pretty sure the answer might be wrong. I might be no, as of now. Just because of the marketing and the sales perspective that goes into the big pharmaceutical companies and having these words out as like officially as maybe like I highly doubt that it will one day become a black box warning. But I think yeah, but I think this point is for sure is very important. There needs to be an action that needs to take place even on part of prescribers to increase the emphasis or even just awareness. And, baby steps day by day once we get all these words out, maybe one day. But thank you.
Thanks, Lucy. Great presentation.
Thank you.
And I'm looking at the chat. I don't see any others. Anybody else would like to come off chat? Do you, I'm sorry, come off mute if you do have a question or a comment for Dr. Lee.
Yeah, my name is Nicole Salisbury. Thank you so much. Can you just explain the definition? Forgive me if you've already done so, but explain the definition of pharmacokinetics again.
So there's two things, pharmacodynamics and pharmacokinetics. Pharmacokinetics is how our body processes medications, and pharmacodynamics is our body's effect on. So pharmacodynamics is I think I don't know if you've heard of it, but ADMA, like administration, and I think D is distribution, M is I forget what M is, and E is excretion. But different from pharmacodynamics, pharmacokinetics is how drugs, like what percent of drug is being eliminated through our renal system, what percent is being metabolized. Oh, I think M is metabolism. What percent is metabolized through our hepatic system, and just like the numbers and the calculations involving drug clearance within our body system.
Okay, thank you.
Mhm.
It can be complex.
Yeah, I think it's a whole field, I think,
Mhm.
pharmacokinetics in general. There are people specializing in
Yeah.
it.
This is just something so interesting. Again, great presentation. I agree with everyone else. And Becky, it seems like something that we really want to include in our next Heat Summit because this is a really, really important issue. I know we have talked about before of how medical examiners may not be capturing um, all the heat mortality that has occurred. But now I'm thinking about all these chronic conditions that may be exacerbated by the heat stress, but it may be because of the medications have been impacted as well, which can lead to uh, adverse health outcomes and mortality. So, um, thank you for taking on this topic, Dr. Lee. I look forward to all of the research coming out of it.
Thank you.
Let's see, Micah, one last thing, I'm sorry, one thing that I hear from the physician side of educating patients is time. And again, the environment heat aspects don't get discussed. Are there one pagers we can use?
Resources we can use for our patients or for us to use to educate our patients quickly. Edu I'm not sure if anything is out there, but I can I can maybe provide that one pager maybe just I know my list like when I was making these slides, the list that I have here, I should have stressed this during when I was presenting initially, but this is not an exhaustive list, right? Like these
Mhm.
medications, the list of medications that we discussed today is not exhaustive at all. There's obviously there's much room for more research or more just more awareness and more clinical attention. But at least for the medications, the list of medications that we discussed today, I can provide that one pager so that you can use or utilize them when you're um, as when you're
Yeah.
educating.
And I'm wondering, Becky, if that's something that Texas PSR can help Dr. Lee produce and we could
Sure.
send that out. Yeah.
I mean, I think if we're talking about a one pager, the just from a, pragmatics
Eh,
perspective, really, really text heavy, one pagers are probably not going to get read by patients. I wonder if we could partner with a graphic designer and make infographics that are, sort of simpler and easier to take in.
Yeah, that's a better idea.
We could try to do that as a project. And Lucy, if you'd be interested in helping, that would be great.
Yeah, of course, of course. I am not very prone to graphic design,
Me
but
neither.
if I can get some help from a professional graphic designer, that'd be
Yeah,
awesome.
at this point, it might maybe even be a student. Like there's a lot of tools.
Yeah, yeah, yeah.
yeah, good point.
You
Yeah.
know, and AI can do so many these
Hmm.
days. So
Fantastic. Thank you. Thank you so much. Thanks
thank
for the
you.
great questions and comments.
Thank you for taking the time today. I know it's
Yeah.
Memorial Day.
Yeah. Well, thank you. Thank you, Dr. Lee. I really appreciate the time.
By the way,
Very, very
I'm sorry.
interesting topic. Go ahead, Becky.
Before we wrap up, I did do a search, not using AI even, just the interwebs, for infographics and medications connected to heat illness. And not surprisingly, the University of Arizona actually has a pretty decent one pager. It's a lot of images on the front page, and then I'm assuming you make it a front back, and on the back, it lists all the medications under their different categories. Um,
Awesome.
I did it on my iPad, so it's not easy for me to share in the chat, but I can see if I can figure out how to do that in just a sec.
Yeah, no
Yeah,
problem. We can certainly use that as a foundation.
yeah.
And I'm sure, yeah, Arizona, certainly with the heat they experience there. All right. Well, we're at 7:50. Um, I don't see any other questions here. Again, Dr. Lee, thank you so much for taking the time.
All right.
And thank you,
Thank
everybody in the
you.
audience, for taking some time this holiday weekend to join us on a very important topic.
I
Uh,
did just
and you
add that
did, Becky.
one
Yeah.
pager. They have a website called Scorch, which is,
Oh,
a great name.
Yeah.
So,
Fantastic.
Micah, take a look at that and see if it's what you had in mind. And if it's not as good as we'd like it to be, we could work on something.
Yeah,
Thank
agree.
you.
No worries.
Totally agree. All
Thank
right then,
you.
everyone. And maybe, and Micah said maybe enjoy join in on that initiative. Yes, of course. Thank you, everyone. Have a very wonderful
Thank you.
evening
Have a good rest of your night.
and
Bye-bye.
a good week. Bye bye.
Bye.